fellow here at the New America Foundation and research director of our Next Social Contract program. We have a very exciting program here today. I want to provide you with a little bit of context. As some of you know, earlier this year I published a book on the VA. Here it is. It's my little plug. It's called Best Care Anywhere, Why VA Healthcare is Better Than Yours. More recently, my colleague Shannon Brownlee has published a book called Overtreatment, which the New York Times has identified as the best book on economics of 2007. And she, in evaluating the problems of the American healthcare system, has identified the VA as a model for healthcare reform. So we are friends of the VA here at New America, and the VA has many other new friends. Hillary Clinton, as you may have noticed in her discussions of healthcare reform, repeatedly evokes the VA as a model for healthcare reform. And within the last 2 weeks, Barack Obama has joined her in pointing attention to the accomplishments of the VA. This is in line with a broad coalition of folks who have academics, healthcare policy wonks, and such, who have somewhat unexpectedly found the VA to be an exemplar of best practices in healthcare. But that said, we know that the VA is at this moment at a rather difficult juncture. We are speaking here as friends of the VA, but we don't want to gloss over the real challenges and problems that the VA faces going forward. Its vaunted electronic medical record system, for example, I think is now under deep distress because of various privatization efforts going on at the VA. And longer term, we have bigger budgetary challenges to the VA. And so today we're going to talk about the VA in the long term, in the big picture, and ask ourselves what it is we can do to preserve this very important institution. The panelists today bring a wide range of perspectives. First to speak will be Dr. Ken Kizer, who is to my right here, who more than anyone else brought about the tremendous transition of the VA in the late 90s through his leadership at the VHA. Ken Kizer, I think, needs little introduction here. He's a hero of mine, and I hope we'll get the attention that he deserves. We also have William Diefendorfer here, who is a partner at Diefendorfer, Hofer & Wood law firm, and who also has served as director of the Office of Management and Budget from 1989 to 1991, and was chief counsel for the Senate Finance Committee, and had a lot to do with the Reagan tax reform. Art Hammerschlag is here, who is with the Logistic Management Institute, but who also has a long career at the VA as a top executive, and brings an enormous amount of personal experience and wisdom to this subject. Allison Percy is the Principal Analyst of the National Security Division of the Congressional Budget Office. Her areas of expertise include military health care, veterans medical care, and veterans disability compensation. CBO has recently published a report, an interim report on the CBO, which, I'm sorry, on the VA, which brings a lot of insight into what's good and what's challenging about the VA's future. And Kathleen Wilbamo, who's director of the Subcommittee on Health on the House Veterans Affairs Committee. She brings her own unique perspective as both a former Army officer and a long-term officer with the American Legion. So without further ado, I want to turn this over to Ken Kizer, who will tell us a bit about the very important work that he and the Commission for the Future of American Veterans have been doing in looking at the long-term future of the VA. Thank you.
Good morning. It's nice to see you all here. Thanks for your interest in the VA. Most of the Commission on the Future for America's Veterans are here, and I should just probably say a word about that. Harry Walters, a managing member of the Commission, can say much more if there are any questions about it, but this is an independent commission that is sponsored and funded substantially by the major veteran service organizations, that was convened a little over a year ago to basically look at the long-term future of the VA and see if we couldn't come up with some thoughts about how the future might look better than what we see at the moment. And the Commission has been meeting on a regular basis over the last year, has gotten to a point where we'd like to air some of our thinking and get some broader feedback on some of the ideas that are currently being considered by the Commission, and ultimately we will be publishing a report which hopefully will be available this summer, if not then, hopefully very soon thereafter, but the target date is around May of this year. If I could, Art, if I could ask you just to, I think I'm the only one, I have a few PowerPoints, I guess a habit that I've gotten too used to using these. But what I thought I would just do is to put this in some context. The Phil was kind enough to reference my role in the VA in the latter part of the 1990s and implementing some changes there that have had a salutary effect in changing the functioning as well as the perception of the VA. Indeed, it wasn't that long ago that it would be hard to imagine publications like Business Week or U.S. News and World Report, Time, other featuring VA as and talking about it as a potential model for healthcare in this country. Indeed, in the most recent issue of the American Journal of Public Health, the December issue, there are two articles that talk or raise a specific issue about the VA as a model for healthcare and talk about some of the lessons that may or may not be appropriate to take away from the VA experience. But the some of the changes that we were able to implement that I think are foundational to the effect that it has had on VA's performance were things like putting in a new management structure, the vision structure, implementing universal primary care. There was a what I consider right-sizing of care. There was a major shift to move care to the outpatient setting where appropriate. And that resulted in some change in need for hospital beds and other things that were actually turned out to be quite dramatic. The implementation of a new capitation-based resource allocation system has been largely overlooked in a lot of the dialogue, but I think was absolutely foundational to aligning the financial incentives with other things that were being done in the organization, as well as driving resources to where the veterans had relocated over the years in the Rust Belt migration. Implementation of the electronic health record, standardizing our benefits, going to things like the national formulary. Indeed, there have been multiple calls for Medicare Part D to think about something like the VA's formulary. As you might imagine, that doesn't go over well with the pharmaceutical industry, but it is an idea that continues to be tossed around and certainly had a very positive effect in achieving savings within the system, as well as making benefits more predictable and consistent across the system. New performance management system, a focus on prevention and health maintenance, a focus on changing the culture to one of transparency and openness, and a number of other things. These were things that we had under our control and were able to change as management of the system. There were a number of other things which we couldn't fix and we couldn't address that are inherent to VA being a discretionary government program. It is just like a whole lot of other discretionary programs out there, and is therefore subject to the I wouldn't say whims, but at least the vagaries of a public political process. One of the issues is stability of leadership. It wasn't that long ago that my tenure as a confirmed Undersecretary for Health was longer than the combined tenures of my 4 successors. Which says something about how unstable leadership can be in an organization. Certainly for the largest healthcare system in the nation, you would hope that leadership would be more stable. The knowledge and the stability of the governing board, recognizing that our governing board is a Congress, a substantial portion of that turns over every 2 years, the committees turn over, the ability to accrue institutional knowledge and awareness of the issues, and just the knowledge that you need to have to effectively govern a large healthcare system is not possible with that type of turnover. Consequently, or in the same vein, I should say, with a 535-plus member board of directors, there is not uniformity in the view of the mission of the organization. And again, as a discretionary program, there are often very different views about whether the VA is actually an employment program, whether it's a healthcare program, whether it's a number of other things, and this gets played out every day across the country. The ability to do long-range and strategic planning is a problem in government everywhere. The age of the capital assets. The average age of VA facilities today is 55 years of age, and many are much older than that. And there are major issues attendant to that. The ability to strategically manage our assets, and VA has a lot of assets to manage. The funding issues, and there are multiple dynamics to the funding issue. How stable is it? How adequate is it? But probably more than anything else that's a problem for managing the system is the timeliness of the funding. When you are in April and May and you're functioning on a continuing resolution, it makes it a bit difficult to do the sort of financial planning that you would expect of an organization of this size and magnitude and importance. The ability to expand services to meet demand. Something that we weren't able to do. The ability to truly encourage innovation. As I think we all have learned, government does not encourage innovation because if you innovate, you make mistakes. And government has essentially zero tolerance for mistakes. And so there's an inherent conflict there in trying to be an innovative organization and yet being governed by the vagaries of the political whims. So there are a number of problems that we simply could not address and that are inherent to the nature of the VA as a discretionary government program. As we look down the road, as the Commission has been doing, we see a future that is not particularly bright for the VA. For a number of reasons, some of which I've already talked about, but I think at the top of the list is simply the unsustainable economic environment that is likely to accrue from the baby boomers maturing, the effect on Social Security, the effect on Medicare, a number of other economic consequences. We have actually, I think, listened to and taken to heart the message from David Walker, who I think has painted a very clear picture that the future is not going to be what it was in the past, and that certainly discretionary programs, no matter what their importance or significant, are at real risk and danger in the future, because the economics are just going to drive some very difficult decision-making down the road. So with that as somewhat of a background, I'd like to change gears and talk about one of the ideas that the Commission, I think, is increasingly attracted to, and at this point we're attracted to it enough to raise it publicly, and we'd like to start getting some feedback on it. But this is the notion that instead of being a non-specified or unspecified discretionary government program, that the VA healthcare service would be established as a specifically government chartered entity. Now, there are a number of government chartered entities in existence. There is no one that is actually a good model for the VA. There's actually not one that's a good model for any of the others, because they are all individually tailored and created to address a specific function or a specific purpose. Perhaps one that we have looked to, at least as far as some of the functionality and guidance that might come close, is the U.S. Postal Service. I hesitate to say that because that often conjures up images that aren't always positive. But from a organizational and structural point of view, there are some similarities there. But anything that we would be talking about here is not a carbon copy of anything else that existed, but would have to be specifically designed and put in statute for the specific mission of the what we call are calling now the Veterans Healthcare Service. That charter would really detail the specifics, the mission, and I think that here we can actually get a lot of clarity about the mission of the VA, the governance structure, funding, personnel issues, whether the personnel will remain a civil service or not, other flexibilities that might be desirable in running a healthcare and scientific organization that often aren't well addressed in the civil service system. We would address issues of asset transfer and where that would exist. There is a long list of laws that would have to be detailed out about whether they would apply or not apply, or apply in part. These everything from the Ethics in Government Act, the Government Performance and Results Act, the Government Sunshine Act, and there are a whole bunch of these things that would have to be detailed out. And again, they apply in part, they don't apply, and that's much of the detail work that has yet to be done. I just wanted to give you one example, and then I will stop and turn the microphone over or back to Phil. But just as an example of the sort of detail that would need to be spelled out in the charter, we would anticipate that this new government-sponsored entity, the Veterans Healthcare Service, would be governed by a Board of Governors. Again, not unlike what you see in the Postal Service. Just as an example only, for example, 9 members who would have specified skill sets detailed in law, for example, expertise in healthcare, or expertise in the service industries, or however that would be detailed out. 9 members appointed by the President with the consent of the Senate. We would suggest that a portion of those, and for this example 6, would be recommended by veteran service organizations, recognizing VA's intimate role with the academic health centers. We recommend one would be recommended by the Association of American Medical Colleges. Think that insofar as they would be governing the Veterans Healthcare Service, that a certain number of them should be veterans. But again, this is just put as an example of how these details might be spelled out. Along with the 9 members who are appointed by the President, we would anticipate, for example, like the Secretary of Veterans Affairs would be a member, and the Secretary would remain a cabinet officer on the President's cabinet. The President and CEO of the system, which the board would hire, would also need to be a member of the Board of Directors. There would likely, as ex officio members, the Assistant Secretary for Health of the Department of Defense, the Surgeon General of the Public Health Service would be logical candidates to be on the Board of Governors as well. And I don't want you to go away with an idea that this is a specific recommendation, but I wanted to lay out enough detail to give you an example of the type of detail that would need to be spelled out in the governing charter and the law. This, obviously, there's levels of detail beneath this as well, but this would apply, and so we're obviously talking about a substantive piece of legislation or a substantive charter that would need to make its way through Congress and ultimately be approved by Congress. So having at least laid out the notion, or at least one of the notions that we are thinking a lot about these days as are having moving current VA healthcare from a discretionary program to a government chartered entity, let me turn the microphone back over to Phil, who I guess will introduce the next speaker. Thank you.
Thank you, Ken. I think, Bill, you're going to come and
Happy to, Phil.
do the heavy lifting here. Thank you.
As Phil said, my name's Bill Diefendorfer. I'm on the commission, and my task today is to describe to you what the new health care entity might look like and how it might operate, more importantly. But it's important to set this in the context of the undertaking. As Ken said, the Commission was asked to look 20 years out and identify the challenges and the opportunities for the VA healthcare system. This is our first time to have a sort of detailed public discussion of what we're thinking. You'll notice some redundancy. We'll get coordinated as we go along. But this was the first step in our process, and it was critical that it's understood the 20-year mandate to look out and see what we saw in the future, because it is those challenges and opportunities that have shaped our responses. We didn't come with a solution to problems that we hadn't determined exist. Ken mentioned, and Phil alluded to, the coming budget crunch. It's pretty simple. Baby boomers are retiring. I missed baby boom by 1 year, being born in 1945. Not sure that's a plus or a minus, but as they retire in great numbers, cost of running government mandatory programs, particularly Social Security, Medicare, soar. We all know that. The head of GAO is sort of a fiscal Paul Revere, riding around the nation telling them it's not the British are coming, but huge deficits are coming. We have to find a way to manage them. We also have, at least temporarily, rising overall budget deficits. These are the challenges. VA healthcare system, infrastructure. Average age of hospitals, I think, is over 50 years old. We haven't built a hospital in 20 years. There's some maintenance to be taken care of. Costs money, of course. As I said, haven't built a new hospital in 20 years, and as Ken said, Rust Belt migration, the veterans have moved. They're not where they were and where the hospitals were built 50 years ago. For example, I believe it's been 20 plus years. We've known we need a new hospital in Orlando, but we haven't been able to build it. That's a challenge. And I've already mentioned that we need routine maintenance and replacement. We haven't kept up with that. And there's an inability to react in a timely fashion to small in terms of money, realistically, but big in terms of impact problems. The commission was in Tampa at the Polytrauma Center, and the gentleman doctor running that facility said, we need $13 million to update some facilities here in X, Y, and Z. Well, that's fine, but if you have to go to Congress, it's a year or two, and they need them now. Those are the challenges. there are also underused assets in the system, and that is a challenge, also as an opportunity. The medical challenges, which Dr. Kizer spoke to, it's his purview. I know zero about medicine, other than I do what my doctor tells me. I summarize them as a more stable and predictable system, a nimble system, a system that must be medically broad enough, broad-based to adequately serve the special needs of our wounded heroes, who often have very special needs, which the VA healthcare system is the world leader in providing. But you can't have a health system based just on those special needs, whether it be amputations, traumatic brain injury. You have to be able to take care of diabetes, kidneys, things that a broader-based system supplies. Many of us can remember the deplorable state of the VA hospital system in the Vietnam era. Today is touted in Phil's book and other places by peer review as the best and the most efficient. The change was in large part achieved by the daring and, I dare say, chutzpah by Dr. Kizer and other dedicated employees of the VA. Dr. Kizer, I believe, got himself driven from the VA because of that, but now he's back on the commission and he's being rightfully lauded. We cannot rely on a system where, for maturation, for advancement, where people have to be willing to suffer abuse, firing, possible damaged reputation to continue constructive change. A new system with a better ethic and a structure would help solve that problem. The opportunities. Well, the biggest opportunity, I think, is we have the best care anywhere. A very valuable asset. If we were here when I came in 1971 or 72 and looking at the VA system, we wouldn't have been able to list that as an asset, but it is an asset now. We have a very large physical asset base, hospitals, clinics, equipment, which is geographically diverse. We have billions and billions of dollars of assets. Some of them are in the wrong place, but they're worth a lot of money. The greatest asset, however, is not our physical assets, it's the healthcare team that's in place now, delivering the most efficient and the best care possible. And then we have our teaching hospitals and our research facilities, huge asset of the system. And we have, I think, an overall arching asset, which is the national commitment to serve our vets. The proposals we have, which are a work in progress, create a new entity, as Ken said, using all the strengths of the old one, with enhanced capabilities to meet the challenges that I've laid out above. How has our nation met these kinds of challenges in the past? Well, we've met them with new entities. You can go back to the TVA. We needed to electrify Tennessee and that area of the country. That was a special government entity. We needed to get housing. Now we have close to 80% of Americans owning their own housing. We created Fannie and Freddie to deal with that, and they were successful. These are special entities. Some were government-sponsored enterprises, some were federal government corporations, and as was said, we are looking at all of them, and we're taking the best aspects of them and trying to put them into another social need, which is the service, the health care services of our vets. An exhaustive study has been done of the existing federal government entities, charters, corporations. MITRE Corporation did it for us. And as I say, we're reviewing those and saying, here are the things that worked in case A, B, C, D. These things didn't work, and we're trying to take the best of all of them to create this new entity. Some of the attributes of the new entity. The overarching, at least from my point of view, and I believe the other commissioners' point of view, the overarching primary responsibility will be to provide care to veterans who have service-connected disabilities and those who qualify for fully paid care under law. The shorthand in Washington is, I think, is Category 1 through 6. That's the primary responsibility. The new entity will own all the assets of the present VA healthcare system without encumbrance. They will have the ability to sell, buy, renovate, and use those to meet vets' needs. For example, if we have a property in, I won't pick a particular city because the politician will get upset, in XYZ city that's it's underused and it's worth $1 billion. We might lease it or sell it and build that hospital in Orlando, or begin to build that hospital Orlando. We will be able to borrow against those assets. If we need $13 million to fix the problem at the Poly-Trauma Center, we won't have to go to Congress to, sorry, Congressman, former Congressman. He would give us the $13 million today if he could. That's not a problem. But we won't have to go through that process to meet emergency needs. The new entity will be able to borrow through the federal financing bank. Fannie, Freddie, for example, Sallie Mae, which is no longer GAC, had that power. It gives them great flexibility. They can borrow government rates and address the needs. And we would, and this is the next one is also important. We have the budget crunch coming. We know that. We need to create new avenues of revenue outside government funding so we will have the funds necessary to keep the system broad and vibrant. We would be able to deliver health care to all vets and their families who have the ability to pay. We have the subsidized vets, the 1 through 6 that I just mentioned, the overarching responsibility. That's not going to change. That is the reason for the health care system to be. But vets like myself who don't qualify for subsidized care, I could take my health care insurance and get the best care anywhere. And would allow people to vote with their feet for a national health care system that they want to enroll in. Now, to give you some sense of what that means is we have 25 million vets roughly out there now. If you multiply that times, say, 3 dependents, a wife, 2 kids, whatever, you're looking at 70 million possible customers for a new system. That is a lot of money. That's a lot of people into a national health care system that is working now. We know it's working, but it's not forcing anybody to go there. Vote with your feet. So I think it's a very strong argument for this kind of system. The new entity would have a long-term contract, which I call, some others call hell or high water contract. And we'll talk about that a little, for let's say 30 years to provide care to the 1 through 6s, the mandated subsidized veterans care. That is very valuable to this entity because it gives them a guaranteed stream of funding. Now, probably everybody in this room understands. I see there's a camera back there, so maybe someone else will see this who doesn't understand Washington speak. There's 2 kinds of spending in Washington. There's discretionary spending and there's mandatory spending. And mandatory example is Social Security, Medicare, and that's high, hell or high water expenses. We're going to pay those. Everything else is discretionary. And lo and behold, for some reason, our system calls veterans discretionary. Now, that just ain't right. A hell and high water contract, the last 30 or so years with health care escalators in it, changes the nature of that contract. That means the government's got to pay the money. It's got to be there. When I speak outside of Washington and people want to understand mandatory and discretionary, and personal budgets, let's say your rent or your mortgage is mandatory. Theater tickets, a night out eating is discretionary. Well, it's clear, I believe, and this is key to this proposal, that emphasis shift. The veterans who have served and suffered are not discretionary. They are mandatory. And this program will, as proposed, I think, right that wrong. Thank you.
Next up, I think, is Art. You want to take it?
Good morning, everybody. Just let me give myself another quick introduction. Art Hammerschlag. I'll confess I'm a career bureaucrat. I spent 30-some-odd years with VA, the last 16 Veterans Health Administration. Let me thank Harry Walters and the Commission, A, for having this forum, and B, for letting me speak. They may regret that in a few minutes, but appreciate the opportunity. And let me say right out front and confess, I'm a fan of the concepts that have been developed here. I think they have identified some real issues, and I think there's a lot of thinking going on to how to address those issues. At the same time, I think in the interest of a healthy debate and making sure the end product is as constructive and functional as it can be, I want to bring up a couple of issues I think that have to be addressed. Before I do that, let me again talk about some of the benefits that I would like to emphasize, and I'm just reiterating what's been said before. The freedom from political influence, I think, is very important. I originally wrote political interference, but I think that has a negative tone, so let's use the term influence. And that's really neither good nor bad. That's simply a fact of life. If you are a creature of the federal government, you have interests in the Congress, in the White House, and OMB and elsewhere that are to some degree aligned with the interest of the mission of the organization, but not totally aligned. And so you are always balancing those sorts of interests. Those interests can be protective of the mission. They can be disruptive. But, you know, the reality of those influences cannot be denied. I will just give one example because I think it's current and important, and that is health information technology. VHA has the world's foremost electronic health record. It's foundational to everything we do. For what I think were a different series of interests, information technology in VA has been centralized to the department. And on a personal level, I have real concern that the department can maintain the delivery of an electronic health record for the future. If you had a government-sponsored enterprise where the organization really had freedom to organize itself, make its own decisions, make its own investment decisions, I wouldn't have those same level of concerns. Similarly, with capital has been mentioned, if you want to close hospital in state X, the senators from that state are very concerned, obviously. So just two examples of what political influence can bring. Concerns or issues, unfinished business, for example. Let me just run through a couple of things. If VA does, in fact, Veterans Health Administration comes directly out of the political realm, if you will, I think it will be trading one set of pressures for another. If you look at Fannie Mae, Freddie Mac, they deal with market pressures. They're in the financial business. They deal with the ups and downs of the market. I think VA will find itself in the medical marketplace in a way it really is not now. And that will, and it's not necessarily a bad thing, but it's a reality that it will have to compete, I think, in a different way with the Humanas, the Health Nets, the Tri-West of the world. So it will find itself in a different environment. In that different environment, I think it will need a different skill set from its top leaders. The skill set necessary to run a government bureaucracy and succeed, I think, is very different than the skill set necessarily to run essentially a free enterprise. You have to worry about finance, cash flow, investment, accounting. Again, I'll give you Fannie Mae's example of accounting issues that have to be tended to. So I think you really have a different set of demands on the leadership. We've had a long tenure, even though Dr. Kizer mentioned quick turnover among his successors, but there's been a consistent sense of mission, consistent buy-in to the culture of VA. The culture has been continuous, and people have built on what was begun. You had no new CEO come in with a hard right turn. Let's throw that away. Let's do something different. So there's been continuity in approach and culture. I think you have to understand that that may be a less of a certainty in the future given what's being proposed. I hope not, but it's just something I wanted to put on the table. Will the health nets and the Humanas and the Tri-Wests be freer to cherry pick people out? Will VA be able to maintain a consistent national health benefit? And you may say, well, of course, that's not an issue. But I give you Medicare as an example. If you go back 20 years ago, Medicare was a fee-for-service program, standard benefit across the country. Everyone got the same thing. Under the Medicare Advantage program today, that is not the case. You have, and again, I'm not saying good or bad, I'm just observing the difference. That Medicare Advantage program in Miami may be very different than a benefit package delivered to Minneapolis. So these are things I think VA needs to think about, really whether this change happens or not. I think the medical marketplace is changing. It's going to have an influence on VA. I think there's some unfinished business that would have to be addressed, and again, not a bad thing. VA is probably the only major health player in this country that doesn't get paid by Medicare, something Dr. Kizer tried very, very hard to address. You can't go into a different environment without being a Medicare payer, without having some notion of coordination of benefits with Medicare. So that's something I think really is an opportunity that this would give us to address those sorts of issues. Federal drug pricing. VA benefits from some very clear law on federal drug pricing. Presumably that would carry over to this new entity, but something that has to be addressed. And when you put the issue on the table, you can bet that pharma and our competitors in the medical delivery world will weigh in. It's not fair, they shouldn't have it, and so on. So be prepared for those sorts of issues. Federal pay structure. You can complain about federal pay structure and we can't pay our docs enough and we have a hard time recruiting, but at the same time it certainly gives you a level of security and certainty on what your payroll is going to be. It doesn't create an antagonistic relationship between management and employees on what the pay is going to be. So are you going to deal with those sorts of issues? What's the pay structure going to be for the rank and file? I think what's being proposed offers tremendous opportunity. It would be exciting to be a part of it. I think there really is something here. I think the important thing is that we all need to do is in the open public debate is identify issues, concerns, potential problems, try to work our way through those intellectually. How do you deal with that issue? How do you put them on the table? How do you get the people to agree that's the right way to handle that issue and go forward? Thank you very much.
Allison, do you want to come and weigh in on what these folks are suggesting and whether it makes any sense? Whether we can afford it?
Well, this is a pretty broad set of recommendations. I didn't really come prepared to respond point by point. We would have to analyze every aspect of it. So if you guys don't mind, I'm really going to talk more about the study that we are doing already and talk about the, what we found out so far, which I think addresses some of the topics about the VA system. And so it runs in parallel to some of these concerns, but it doesn't address all of the recommendations that your commission is coming forward with. Oh, I'm sorry. I'm Allison Percy at the Congressional Budget Office. So, with the return of veterans having served in the conflicts in Iraq and Afghanistan, and with a much larger number of veterans from earlier eras turning to the Department of Veterans Affairs for at least a portion of their health care, the number of patients served by the VA medical system has increased substantially. At the same time, VA's ratings for quality and customer satisfaction have apparently improved. CBO began a study last year at the request of Congress to examine some of the evidence on the quality of VA's medical care and the incentives for quality that VA has included in its performance measurement system. This study is also examining ways in which the department's use of health information technology may affect the quality of care. This study is still underway, with an interim report released late last month. I think many of you picked one up at the table outside. The Department of Veterans Affairs operates a system comprising over 150 medical centers, nearly 900 ambulatory care and community-based outpatient clinics, hundreds of other facilities including vet centers, nursing homes, residential rehabilitation and treatment programs, home-based care programs, and more. These facilities provide a wide variety of services to eligible veterans, including inpatient hospital care, outpatient care, rehabilitation for a variety of disabilities and conditions, mental health counseling, and even custodial long-term care. In 2006, the department provided medical services to over 5 million of the 24 million veterans in the U.S., and also provided services to over 400,000 other patients. An additional 2.9 million veterans were enrolled in VA's system, but did not seek services from the department that year. The Veterans Healthcare Eligibility Reform Act of 1996 altered eligibility for VA health services. That law called for veterans who desire services to be assigned to a priority group based on service-connected disabilities, service-related exposures, income, assets, and other factors. Currently, there are 8 priority groups. Those in the highest groups, 1 through 3, have service-connected disabilities of various levels. While those in priority group 4 have serious disabilities that are not service-connected. Priority Group 5 consists of low-income veterans, and Priority Group 6 includes those with environmental exposures to Agent Orange, for example, as well as many recent combat veterans. The veterans in Priority Group 7 and 8 have no compensable service-connected disabilities and have higher income than those in Priority Group 5. The medical care needed by veterans in each of these priority groups differs, with more disabled veterans generally costing more than those without disabilities. In addition, veterans in some priority groups rely more heavily on VA for their care, while others receive the majority of their medical services from other sources, such as Medicare, Medicaid, employer-provided private health insurance, the military health system, or public hospitals. In addition to the 7.9 million veterans currently enrolled, VA estimates that nearly 6 million veterans who are not enrolled would be eligible to receive medical care from VA if they applied, and that about 10 million veterans would be classified into Priority Group 8, for which new enrollment has been frozen since January 2003. Recent combat veterans may enroll regardless of disability or income status during a 2-year special eligibility period. To serve the population of eligible veterans, the Veterans Health Administration received $36 billion in budget authority in 2007, including collections and supplemental appropriations. A few news articles and publications have noted that the cost per patient or per enrollee has remained relatively stable for the Department of Veterans Affairs, while the costs faced by Medicare and other health plans have risen faster than general inflation. By one measure, the budget authority per enrollee for the VHA, the cost fell by 5.6% per year in real inflation-adjusted terms between 1999 and 2005. However, those figures do not take into account the changing mix of patients within the VA system, which has seen rapid growth in the overall number of patients, and particularly in enrollment by those veterans who, on average, are less expensive than for previous patients. Those less costly enrollees include patients who are younger, for example, the recent combat veterans, some who are less disabled or who seek only a small portion of their care from VA, as well as some enrollees who do not seek any care from the department in a given year. Adjusting for this changing mix of patients using data on reliance and relative cost by priority group that was provided by VA, the Congressional Budget Office estimates that VHA's budget authority per enrollee grew by 0.3% annually in real terms from 1999 to 2005. Now, this isn't the decline in cost per capita that is suggested by the unadjusted figures, but it still indicates some degree of cost control when compared with Medicare's real rate of growth of 4.4% per year in cost per capita over the same period. While VHA's real per capita spending has increased little in recent years, the agency's overall spending has grown rapidly. The agency's medical budget has doubled in the past decade, rising from $17 billion in 1996 to $36 billion in 2007, reflecting an annual compound growth rate of 5.2% in real terms. That growth in the agency's budget can be traced in large part to a rapidly expanding population of enrollees, from 4.2 million enrollees in 1999 to 7.9 million in 2006. However, in any given year, some enrollees do not seek care from VA, either because they do not become ill or because they rely on other sources of care. As noted earlier, in 2006, about 5 million veterans received services from a VA hospital or clinic, up from 3.2 million in 1999. Many new patients who have entered the VA system fall into priority groups 7 and 8, veterans with no service-connected disabilities and with income or net worth above established thresholds, who previously had very limited access to the department's medical services. Those groups differ in some ways from VA's traditional target population. Many enrolled veterans in those groups are older but have access to other sources of care, such as Medicare. On average, veterans in priority groups 7 and 8 receive only about 20% of their care from VA and the rest from other sources. VHA's current spending reflects only a fraction of the potential costs that the agency could incur if all veterans enrolled and sought 100% of their care from VA. In addition to the influx of older veterans in priority groups 7 and 8, recent combat veterans are enrolling in much higher numbers than recently discharged veterans have traditionally. Perhaps partly because of the special eligibility period currently in place that allows them to enroll regardless of their income or service-connected conditions. Those enrollees are younger than the average for VA patients. While some of them have serious injuries, most are relatively healthy. The average cost for patients with special eligibility status is about $2,600 in 2006, compared with about $5,800 for all VA patients. Now about the reengineering. In the 1990s, VA's then Undersecretary for Health, Ken Kizer, led a reengineering of the department's health system with the goals of better managing performance and systematizing improvements in quality and innovation. Dr. Kizer has already given some description of these changes, but the focus of the study that I'm talking about now is to examine VA's efforts in those areas and to see what lessons might be drawn both for VA but importantly for other providers in both the public and private sectors. One part of VHA's reengineering was the establishment of regional Veterans Integrated Service Networks, or VISIONs, which include 7 to 10 hospitals and a number of outpatient clinics and other facilities. Rather than providing funding to these VISIONs on the basis of historical budgets or on the basis of the number of services provided, a system known as VERA, or Veterans Equitable Resource Allocation, was created to allocate budgets to those VISIONs on a more or less capitated basis, with some adjustments to account for the number of complex patients seen in each VISION. VERA was designed to give managers incentives to provide care to patients in the most cost-effective and medically appropriate settings. For many private providers, fee-for-service payment creates an incentive to perform more billable services and procedures. In contrast, VA's structure as a vertically integrated system that operates on an appropriation does not provide that incentive. This structure may have made it easier for VA to apply 2 important tools to aid in its quality improvement efforts: incentives given to managers and providers to meet targets for quality of care and adherence to clinical guidelines, and health information technology systems, which include reminders about tests and treatments recommended according to clinical guidelines. Accountability for performance at all levels, from senior executives down to medical providers, is also an important part of VA's reengineering. VA's experience demonstrates the potential for improving a system's performance by sustained efforts to monitor indicators of quality, access, and satisfaction. Most of the criteria that VA uses for assessing the performance of senior-level executives, mid-level managers, and even healthcare providers relate directly to indicators of quality, access, and satisfaction for the facilities or units for which the individuals are responsible. The result has apparently been improvements in many of the indicators, suggesting that tracking such indicators closely and consistently may be important to improving a healthcare system's performance in those areas. For every patient, VA has an electronic health record in an information system, the Veterans Health Information Systems and Technology Architecture, VISTA. The system was developed by VA programmers beginning in the 1970s with the input of providers who would be using the system. VISTA is integral to both VA's system for providing care and its management of both providers and executives. Moreover, VISTA is often cited by VA officials as a key to the department's efforts to achieve high-quality ratings and in helping to control medical care costs. Research on the impact of health IT has highlighted some of its potential advantages and raised many issues about the feasibility of implementing such information technology in healthcare systems composed of diverse providers and payment mechanisms. Many experts cite the potential for health IT to improve the quality of care. Improvements in efficiency may enable providers who use health IT to reduce costs as well, although the evidence about cost reduction is mixed. VA may be particularly well positioned to take advantage of health IT's potential. Independent providers who interact with a variety of insurance systems may have a harder time realizing those benefits. Issues of interoperability, the standardization of formats and records, privacy, ownership and control, and the education of and compliance by providers are all challenges to successful implementation that are far more difficult in a non-integrated environment. But even VISTA, which has been in place for a number of years now, has a very limited ability to interact directly with or use information from other electronic health record systems. Despite the fact that many VA patients receive a substantial portion of their care outside the department's system. VISTA is able to draw some information from the Department of Defense's health information systems regarding the medical history of recently discharged veterans or patients receiving services from both military treatment facilities and VA hospitals or clinics. For non-DoD providers, such as private hospitals and doctors, information can be brought to VA by the patient or sent by the outside provider and then entered into VISTA manually. Paper records can be scanned and attached to a VISTA record, which allows providers to access them while reviewing a patient's file, but the information generally cannot be searched or used for monitoring or quality systems within VISTA. CBO's interim report reviews just a few of the studies on quality on the quality of VA healthcare and how consistent tracking of quality measures and the use of health information technology may have helped VA improve its performance, particularly with respect to adherence to clinical guidelines. CBO is continuing this study now, and the final report is anticipated later this year.
Thank you so much, Allison. Next up is Kathleen with the House Veterans Affairs Committee. And I hope, Kathleen, you can speak something to the question of veterans advocacy. And because I know you have this background with the American Legion, and I'm very curious to know what your perspective is on how the younger generation of veterans is organizing and how the current VSOs, how effective they are politically in advocating. Thank you.
Good morning. It's a pleasure to be here today. Before I get started, I'm going to go a little bit over my background, but I wanted to say thank you to Mr. Walters. It's a pleasure to be here and an honor to sit on this panel with Dr. Kizer, former Undersecretary for Health, and all of these very esteemed colleagues. I thank you. And I'd like to acknowledge Mr. Ron Conley, who is past National Commander for the Legion, also a member of the Commission, and my first year as the Healthcare Director for the Legion, he was the National Commander, and that was certainly a baptism by fire for me. We visited many, many VA medical centers, and I'd like to thank you for your mentorship. And so, by way of background, I'm an Army officer, United States Army officer. I'm also a disabled veteran. I served nearly 10 years in the Army. I've worked at a VA Medical Center. When Dr. Kizer was the Undersecretary for Health, I was a GS4 at the VA Medical Center in Huntington, West Virginia. I worked as a claims reviewer at Fort Lewis, Washington, where I worked in the program that now is the BDD. It was the precursor to that, so I have some background in veterans claims. I worked at the American Legion National Office in Washington, D.C. for over 7 years, working all three of the VA's administration's issues over those 7 years. I was a member of the VA's Advisory Committee on Minority Veterans. I belong to the Disabled American Veterans, of course the American Legion, and the Military Officer Association. So I've been with subcommittee just about a year, 8 months as the subcommittee director, and I say this because when I heard Dr. Kizer say, well, the committees change over and Congress changes over and there's an education process, comments were well taken. That is definitely an issue up on the committee. So as most everyone in this room is aware, providing health care to veterans is very different from the private sector. Veterans, by the very nature of their service, fall into a category all of their own. They routinely are exposed to unique harmful conditions such as combat, exposures in foreign countries, exposures to harmful chemicals, and encounter training hazards. As we examine veterans' health care and discuss the need for reform, or whether it should be used as a model for the rest of the nation, or both, or neither, I think it is important to ensure that the mission of VA does not get lost. Today, VA delivers a wide range of services to highly diverse populations while maintaining high-quality services overall. VA must maintain the capability, flexibility, and funding to adapt and change rapidly. It should never be business as usual. The advancements we have seen in technology, pharmacological research, research in genomic medicine, and many others will help shape the mission and the future of VA healthcare, how it is delivered, and how effective it is. Future advancements in areas such as these cannot help but dictate what VA healthcare will look like in the future. As we all know in this room, VA is a closed system. The VA's patient population is poorer, sicker, and older than the general population. Not everyone is allowed. You have to be a veteran. Generally, you have to be eligible, you have to be service-connected, catastrophically disabled, or poor. Some of the challenges faced by VA today are pretty unique. The wars in Afghanistan and Iraq laid at VA's doorstep new challenges for the committee and the agency. Polytrauma treatment and care, that's been mentioned. They have come a long way in that regard. They have a much younger cohort of patients compared to the Vietnam-era veteran as well as the aging World War II veteran. They are now in the business of handling distraught family members. Transition issues associated with the polytrauma patient coming from the DoD system of care into the VA system of care has posed many problems for VA. They are now dealing with a very plugged-in, well-educated veteran who uses the computer for everything. They have had to shift their outreach and how they view the veteran and where they go to find the veteran over the past 4 or 5 years. There is a high demand for high-quality patient care. Keeping track of and treating the National Guard and Reserve soldiers is a challenge for the VA. And there's also, and I would be remiss not to mention this, a growing women veteran population. And many of them are now combat veterans. And they have very unique needs. And the VA is now looking at that. They've been looking at that for a few years. They have an aging employee population. Today's veteran wants to see someone that looks like them, treating them, someone who understands their language and their experiences. Dr. Batras, I was speaking to him the other day, and he gave the analogy of, he's the head of the counseling services for VA. He said he didn't know what a blog was, but Generation Y and the GWAT veterans, that's how they communicate. They communicate by email, and they blog. They go to the internet. So they have had to do a shift, a significant shift in how they reach the veteran. Also, since the wars in Afghanistan and Iraq, the visibility of the issues facing VA has certainly intensified. Every move they make or don't make is scrutinized. It is arguably some of the most intense the agency has undergone in its very short 20 years as a department. Maybe Dr. Kizer might have something else to say about that, but in my experience, it's been about right. This brings me to the committee, and what's the committee doing about it? What are we doing? In 2007, we held a hearing on opening the VA system back up to Priority Group 8 veterans. I know Allison touched on this a little bit. The Veterans Healthcare Eligibility Reform Act of 1996 ushered the VA into the modern era of medicine. In the decade that's followed, VA has remade itself into a healthcare system that is a model like no others. In January 2003, then Secretary Anthony Principi, who I thought was going to be here today, I guess he's not, made the decision to bar enrollment of new Priority 8 veterans. These veterans are not compensable, non-service connected, and have incomes above a certain threshold. I think it's over $27,000 right now, but under 28. They also fall above the geographic income threshold established by HUD. They, although comparably better off than their fellow veterans who fall within Priority Group 7, they are by no means rich. For 4.5 years, they have not been able to access VA health care. The VA has estimated that reopening enrollment will bring in an additional 1.6 million veterans and require an additional $1.7 billion. In October of 2007, the committee also held a hearing on funding the VA of the future. Concerns had been raised by the veteran service organizations regarding the sufficiency, predictability, and the timeliness of funding provided by the annual congressional budget process. The committee absolutely recognizes the challenges VA faces when the funding is not timely. Over the last decade, VA appropriations have not been in place at the start of the fiscal year. Between fiscal year 98 and fiscal year 2002, the VA operated under a continuing resolution for an average of 30.4 days. Between 2003 and fiscal year 2007, the average was 105 days. Decisions made to keep the current discretionary funding process or switch to a mandatory spending mechanism have direct and indirect consequences to healthcare quality and access. We must consider how to maintain and improve the quality of VA healthcare and the incentives and disincentives under either funding mechanism to veteran access to care and cost containment. One more thing I'd like to mention. You had asked me to maybe address the advocacy. Make no mistake, the veteran service organizations have a lot of political clout on the Hill. Veterans issues are the issue of the day. And as might be expected, OEF, returning veterans, that type of service. You know, how's the VA doing? Do they have enough staffing? Do they have enough money? Those are all huge issues, and I know from the chairman's perspective, the committee's perspective, that VSOs are relied upon. He meets with them, and we take their input seriously. So, just so you know. One more thing I'd like to mention, which hasn't been mentioned today, and well, first let me say that this is the first time I've seen the what's it called? Proposal. Yeah. So I'm not really prepared to address it right now, but I really look forward to some interesting discussions and possibly other, you know, things going on. So I look forward to looking into that. That's a different concept. But one thing that has not been mentioned today is the PAYGO rule. I know Mr. Steve Robertson's very familiar with PAYGO. All I can say is if you switch VA healthcare to mandatory spending, and I know I'm not telling anybody in this room something they don't know, it becomes an entitlement, and then it becomes, unless you cut some other entitlement, you can't make any changes to it. So somebody else has to lose out. And the committee's jurisdiction obviously doesn't fall into that. But I will tell you that I do look forward to discussing the points that have been brought up today. So thank you very much, and I look forward to your questions.
Well, I'll take the moderator's prerogative and ask the first question, which Kathleen alluded to. From the perspective of some of us on the outside and trying to make sense of the VA's transformation, one of the things that occurs to us is that the very fact that the VA has to justify its budget every year and has to work with limited funds was a spur to innovation. That if it had this big fat trust fund that guaranteed it all this money in the period, Ken, when you were running it, you might not have been quite as innovative as you were because you would have had this guaranteed pot of money. You wouldn't have had to, or the doctors at the VA wouldn't have had to operate on a system of a unified budget where, you know, what one patient gets, another patient doesn't get, and the spur to quality and triage that creates. So I wonder if you could speak to the question of how do we prevent the VA that you envision from becoming just fat, dumb, and happy with its hell and high water budget?
I doubt that there will ever be sufficient funds that the VA will find itself in that situation. I mean, quite bluntly, there's certainly with the demand. I think just to put some numbers on what you cite, in the 5 years prior to my tenure, VA budget increased to, if I recall correctly, about 43%. During the 5 years that I was in office, the total VA health budget increased 6%. And in the subsequent time since I left, VA budget has increased about 130% or so. So in essence, if you recognize the rate of healthcare inflation, during those 5 years when a lot of these changes were underway, we were taking a cut every year. Now, there was a special circumstance that basically a deal was cut with OMB so that we could retain any savings that we accrued, which allowed us to offset some of that cut. But we all knew at the time that was a non-sustainable prescription for the future, that we could operate without significant budget increases for some period of time by reducing inpatient care, closing, laying off staff. I mean, there were a variety of things that were done, negotiating better deals on drugs. But that was certainly not something that was sustainable in the future. Clearly, it was a stimulus that facilitated some of the change, but it also, I think it had a price associated with it as well. But to go back to the basic point, the demand for VA care is so great, and the needs are so extensive that I just can't envision the VA ever being in a situation where it's, overfunded. Certainly not in the foreseeable future.
Could I chip in on that?
Sure.
Having once been the chief counsel of two fairly large Senate committees, Finance and Commerce, I learned pretty quickly there are two basic obligations of congressional committees. One is to enact laws, and the other is to oversight. The fact that this would become mandatory, in a sense, a long-term contract, does not relieve the congressional committees of oversight responsibilities. Now, that said, congressional committees are very, very lax in oversight. They like to enact laws and say they're doing things, but the responsibility for the oversight lies with them, and that's the kind of discipline that you're asking for of the budget. And it should be there, and one would hope that it would be there.
Well, thank you. Let's open it up for questions. Do we have any? In the back there, please.
I'm Shannon Bradley.
Oh,
I'm
Shannon,
a colleague
okay.
of Bill's New America Foundation. And one of the things that Phil pointed out about the VA system that's one of the more powerful pieces of it is that it has the responsibility for veterans from almost cradle to grave. And this creates very different incentives than private insurers have in terms of preventive care, in terms of continuity of care. How would you encourage people who are coming into the VA system, this new population of veterans and their families, to stay in the system so that you could keep that continuity of care incentive for your system?
Just as a first stab, I think one of the obvious answer is by the quality of the customer service and the quality of the health care that's provided. A case in point, my brother-in-law works in the media and has his choice of where he can obtain service. He's a veteran, happened to get enrolled in the VA sometime in the latter 90s, and he can't say enough good things about it because the quality of care that he gets there is so much better than he got in the private sector. And he's not one that likes to go, doesn't seek health care unless he really has to, but I think that's the type of anecdote that tells a lot, and people vote with their feet. And so I think what we envision is a system that competes with the private sector. We compete on quality, we compete on service, we compete on price.
I'm Nancy Ampersite. I'm the Chief Medical Officer of a 501c3 nonprofit organization called World Vista. We believe very strongly that Vista has been very helpful in improving the quality of care inside the VA, and he has been kind enough to really distribute Vista outside the VA, but it hasn't been utilized much. And we've been trying to make sure that Vista is used outside the VA, and one of the projects we are working on is trying to improve the interoperability of Vista with other outside systems. The software as provided, we enhance to try and make it available to reduce costs and improve care outside the VA, and it is free of charge. And I would like to see the VA continue on in that manner of distributing software. One of the things that's going on inside the VA now is that they're taking some of the systems over to commercial systems, which is going to increase the cost. This is being used now in several organizations. Many more are looking to bring it on board, but are now concerned because of the going through commercial software instead of continuing the innovation with the VA. It's also being used worldwide. Instead of it's been deployed in Mexico, it's being used by about half the population. It's going to be deployed in the Middle East. And I would like people to consider the use of VISTA outside as a way to control costs, as opposed to bringing those patients in that you're talking about. Let's make it easier for people to have low-cost electronic health records and good care outside the VA.
Well, you're actually involved in that, right?
Well, there's a whole lot that one could say in response to that. I think the point's well taken, and certainly applaud World Vista and all the good things that it has and is continuing to do. I think there's a lot of concern about folks who are watching the VA, and particularly IT in the VA, about some of the recent evolutions and changes in management, and I think that's still a story that the final chapter hasn't been written, but I think there is good reason for concern. At the same time, recognizing that VISTA is an aging system, does need some updating and refreshment, as we might say, and also recognizing that VA operates in a different business model than most private sector settings, and there are some significant as such, the VISTA has some holes that does not make it usable in the private sector. Just to give one example, the VA uses Social Security numbers as a universal identifier, and that makes it very easy to track patients. In the private sector, that's not the case, and a patient may have 4, 5, 6, 10 different identifiers depending on which facility they may be seen in, and if you try to get all their health information, you have to be able to track and have access to all those different identifiers if you're going to incorporate that. But there's a whole host of things, and that takes us away from, I think, the focus of where we are with this morning's discussion.
Just a quick point. Agree with what you said, but recognize that this administration has recognized the value of health IT, has put forward an initiative to have electronic health record available for every American by, I think, 2014. Rob Kolodner, a former VA employee, is over at HHS as the National Coordinator for Health IT, and is working, I think, very hard and very successfully to develop a standards-based electronic health record, so you can have plug and play between commercial systems and Vista and so on. So if that work is successful, my hope would be that one, it would help Vista sustain itself, but also be more interoperable with the private sector systems.
In the back.
So a question primarily for Dr. Kizer, but for the whole commission as well. Will your report have recommendations about the planning and the time to implementation? Noting, for example, that Holland has maybe the closest parallel. They spent 20 years to plan a change from a pretty much government-run to a mixed system, and then they began implementation in 2006. Jonathan Peck.
Yeah, I'm familiar with some of the evolutions that have gone on in the Netherlands, and I'm not sure we would anticipate a timeline quite that lengthy. We expect the report will include some recommendations for timeline and moving forward. We also would anticipate that, given the substantial change that this would entail, that this won't happen overnight either, and that there will be a healthy and probably vigorous debate, and a lot of voices will need to be heard. But ultimately, we hope we'll come forward with recommendations that will carry the day.
Against the wall.
Yeah, thank you. My name is Robert Buck. I teach a healthcare study of the industrial cause of the armed forces. And I have two questions, which I hope are short, and I hope we shoot down in the weeds. But you referenced people who are not seeking care at VA who are enrolled but not seeking care in a given year. I was wondering if you could distinguish between those two categories you mentioned in your data. Can you tell how many were not seeking health care at all in that year versus how many were seeking health care somewhere else? And also, I noticed in your report that you report the percentage of health care from VA versus other sources for each of the categories, but I didn't see the overall average in there. And I was wondering if you have that information.
I don't have the overall average with me. I might be able to dig it out from data that VA sent me. In terms of can we tell how many people are not seeking care at all versus how many people just aren't seeking it from VA, I don't think VA can tell that readily from its information. It might be able to do a match for Medicare eligible patients because they use Social Security numbers and because they have, as a government organization, they have access to Medicare data and they can match the Medicare data to the VA data. So they could probably identify for the over 65 population what percentage were not seeking care at all in a given year versus what percentage had sort of enrolled for VA in some previous year and then just hadn't, they were going somewhere else. Now, for a younger population in any given year, it's not unusual for someone to not seek any care at all. For older populations, particularly as chronic conditions become more of an issue, to not seek care at all in a given year is pretty rare. So, say you're over 70 population, it gets rarer and rarer to have no care. So I don't have that number offhand.
Let me just follow up with that. It would be very useful for the debate if we could say something like, when a patient moves from Medicare to the VA, the cost savings to the taxpayer is X. Are we anywhere near being able to develop a statistic like that?
There is some data, I think very provocative data, looking at the Medicare Plus plans, the Medicare Advantage plans, that show a significant number of those users also utilize VA care. And at least it's informally reported that sometimes they're encouraged to do so by their plans, and that the net effect is that the government is paying twice for those patients. It's paying the Medicare Advantage plan, it's also paying the VA, and that the net amount is a substantive figure, many hundreds of millions of dollars.
Other questions? Yes.
Hi, Marilyn Park, American Federation of Government Employees, and Ms. Wiggler mentioned something regarding the aging workforce. I want to thank your committee for the opportunity for employee representatives to talk about the problems of high attrition and the inability to recruit and retain people the way we used to at the VA. And that's probably why we have both an aging healthcare workforce and also on the benefits side. I think that's true too, that we have a large number of people retiring. And I'd like to know, I think during Mr. Kizer's tenure, I think that there was less of a problem with recruitment and retention and less attrition. And I wondered what we could do to get the workforce. There's lots of people coming in, both who could be medics, turning into healthcare providers from the current combat. Certainly, veterans needing work opportunities in the VA is a natural place for them, and I don't think that we're doing as much as we could. And I wondered what else we could do to bring this workforce in line age-wise and more stable with the needs that we have today.
Is there a question there?
Well, she highlights an issue that's generic to healthcare, not just the VA, but there are significant personnel shortages across the board in healthcare. Different types of technicians, nurses, depending on where you are in the country, the specifics vary. But the aging workforce is an issue with healthcare in general, not just the VA. And it's a phenomena that I think the whole enterprise needs to address.
Phil, can I
Sure.
jump? Although it doesn't have to do with what we're here to discuss today, one of the things that the Commission is doing is seeking to create a registry of email addresses, and every veteran will be able to sign up. So we create a community. And right now, the VA, if they wanted to contact people who were discharged or mustered out within the last 90, 100 days, they really have no way to do it, no organized system to do it. Same with the Department of Labor. By creating this registry, at 300,000 people muster out a year, if they would, DOD would make it part of the muster out process, the Legion, the VFW, Disabled PAV, and others would say to their members, you can sign up. We could create a forum that the Veterans Administration healthcare system would say, hey, look, we've got 100,000 jobs. Here's where they're located. Veterans can tie directly to it, and they can be directly contacted. So it's not part of this particular part of what we're recommending, but it is something we are not going to only recommend. I think we will have it operable within 90 days, and then hopefully get everybody to sign up who are veterans and use it for these kinds of purposes.
And I think that coupled with, genuine enforcement of veterans' preference rules, they are really lax. They don't follow through as much. I think that will make sure you get them in there and they get priority. They should. Thank you.
Great. Well, I think I have time for one more question, and then we're out of time. Eric?
Dr. Kizer, there's been much talk about in this town about a veteran and his family, and a military member and his family or her family. And yet at DOD, we know in a transition process that the family is cared for in the process in the Department of Defense. When he transfers over to the VA, the word family kind of gets cut out. Would you talk a little bit about our discussions we've had internally about family, what family means to the VA, and what we might do in that regard?
I think one of the potential opportunities that this new structure provides is to open the system up to families, assuming that the veterans are getting care. Health care is a family issue, and especially among older individuals. One of the complaints, requests, whatever label you want to put on it, that I certainly heard a lot of over the years was a aging veteran who says, can't my wife get in to see it, make it a whole lot easier? We don't have to go to separate providers. We could come at the same time. And indeed, the system could be set up to do that. The military recognizes that and does have mechanisms to deal with that. I think it's unfortunate that the VA has not been able to accommodate families. I think it would be a immensely popular thing to do, recognizing again that our primary obligation is to a set of veterans, but there is, with rare exception, capacity that could be expanded to accommodate family members, and I think it would be, as I said, hugely popular among veterans.
One last question for myself. If you did go to that model and brought in family members who would be paying premiums, presumably, is it possible that this new VA entity could anywhere near make money?
Well, making money in healthcare is kind of requires a new set of economics. Healthcare economics is, let me step back. There certainly would be the potential to bring in increased revenue that would allow one to deal with some of the physical plant and other issues. I can't see VA in a position for a long time where it would actually be making money in the sense that it would not be having it turned around and spending it again right away. But under the model that we envision, we certainly envision the government continuing to be responsible for veterans and the service-connected veterans. The federal government creates armies. The federal government wages war. The federal government has a responsibility to take care of folks who have borne the cost of battle. Having said that, and with that core funding, the potential to expand services and take care of additional people that would brought revenue with them would allow, I think, for a very robust system, and would allow the system to pay for many of the unmet needs that currently exist within it.
Mm-hmm.
I have a question. And I'd asked earlier Mr. Diefendorfer there, has the commission looked at TRICARE? I mean, when you, like he said, you kind of looked at maybe merging them, but you figured politically that wasn't going to work. Do you plan on looking further into that or just leaving it alone?
Harry, I welcome your comment. The Commission has looked at it, did not find it as attractive as the, at least to date, as the recommendation that's been advanced so far. There certainly are a lot of issues attendant to TRICARE that I think would have to be addressed in very significant ways before it would be attractive to a lot of the veteran population.
Okay.
And one of those is bringing the families along. And if our system would allow them to bring their families, it would be, I think, much more attractive. But once again, I think we're a strong believer in having people vote with their feet. The retired military have a system. If they're happy with it, well, that's something they should be able to exercise, a right to exercise. But if we can provide a better service, a more efficient service, we would be happy to have them in our new enterprise.
Yeah, the realization of looking at the transition issue between DOD and VA, it was clear, you could see, was an ownership issue. Who owns the soldier and when does he become a veteran? So you have two owners clashing at the border. Basically what it is, and there's no man's land. I mean, it's all squeezed in. And the military healthcare system, as we all know, has been stressful for years in terms of its size and in terms of its future. There are many questions where the military healthcare system might go. We were compelled to at least look at what the DOD's future meant to VA under the concept we were looking at. Mm-hmm. And we decided that it was a bridge too far for our commission. It's a good idea. We'll probably mention the idea in our final report, but we don't have the time, nor the energy, nor the resources to pursue that, along with what we're doing with the veterans.
Thank you.
Well, thank you very much, everyone. We're out of time. I'm sure folks will hang around and we can discuss things further. Take care.
Thank you, Phil.